I'm your host, Dr. Kohli. I'm an associate adjunct professor in the cardiology division at Duke University and the founder and medical director of Cherry Creek Heart in Aurora, Colorado. And today, I'm so delighted to be joined by my friend and my colleague, Dr. Matt Budoff. Dr. Budoff is a professor of medicine at UCLA and the endowed chair of preventive cardiology at the Lundquist Institute. Welcome, Matt.
Oh, thank you. It's a pleasure to be here.
Now, in addition to also being the Richard Gere of cardiology, as we like to call him, Dr. Budoff is an expert who's published much of the data that guides us in plaque biology and how to use coronary CT angiograms to really think about how the plaque changes. Now, before you start to sort of glaze over, because I'm talking about plaque biology, stick with me here, because some of what you're going to learn today about how lipid-lowering therapies modulate plaque, meaning they change how the plaque looks and how the plaque behaves, is really going to help cement your knowledge of how to use some of these lipid-lowering therapies. So, before we get into the weeds of the medications that change the plaque, Matt, could you give us a little bit of background on how we assess plaque morphology in 2024 and what makes a plaque more stable or socked in versus more angry or unstable? What are the characteristics that you look for in CT?
Yeah, so with coronary CT angiography, injecting a little bit of contrast in the arm while we do the CT, we get a lot of information about plaque. We can see not only the stenosis severity, how tight is the artery, but how much plaque is there, and beyond that, what type of plaque is it? Is it calcified plaque that may be more stable? Is it unstable plaque, what we call necrotic core, which looks darker on CT? And we can measure these quantities and take a look and see what a lesion looks like, not only how tight, but also is it one of these, as you described, angry plaques that have a lot of vulnerable plaque and soft plaque, or is it an older, more stable lesion that may not rupture and may be much safer for the patient?
I think that's brilliant because we spend so much time in cardiology thinking about the degree of stenosis. And what you're pointing out here is that we actually don't just have to think about how the plaque looks, but how it's behaving, because presumably a more stable plaque, even if it's more stenotic, could actually be a better phenotype than a less stenotic, more unstable plaque. Would that be accurate?
Absolutely. I think that, when we think about an 80% blockage in the left anterior descending artery, the widowmaker, we go, oh my gosh, maybe you need a stent. But we've learned a long time ago that stenting these random lesions, what we call the oculostenotic reflex, where we see a high-grade stenosis and we want to make it look better, is not the right answer. And understanding the plaque biology, understanding is that lesion going to rupture? And a lot of times it's that 30% stenosis that's more likely to break free, go from 30% to 100%, and the patient goes from being asymptomatic to having a heart attack or sudden cardiac death. So it's those milder lesions that we actually sometimes worry more about.
Such important insights. I like to explain to my patients that you could have a plaque that looks like an egg, a raw egg that ruptures and spills into the artery, makes a mess, or you could have one that's a hard-boiled egg that's sort of socked in there. So, with that background in mind, take me through a little bit about what LDL-C lowering medications do to plaque and how some of it helps the plaque to evolve and change over time.
Yeah, absolutely. And obviously we have the most data with statins in this arena, but when we put a patient on a statin, the stable plaque, the calcified plaque, the fibrous plaque actually goes up a little bit. It actually walls off that artery, turns that raw egg into a hard-boiled egg and prevents future plaque rupture, because it's all about that fibrous cap and how thick it is, and the thickness of that cap separating the vulnerable plaque from the artery itself is what's important. Now you have statins, they might increase the calcium a little bit, but they get rid of the lipids, they get rid of the soft plaque and the necrotic core. They make the artery more stable and therefore really decrease what we call non-calcified plaque, which is a primary endpoint of many of our trials that we've done.
It's such an important point to make as well, because we often see the calcium score going up on statins, and then, primary care doctors, patients, everybody sort of panics when they see that. But your point is that a calcified plaque is a better phenotype than a non-calcified plaque, which you might not have seen.
Absolutely. On a calcium score, still, those people have a lot of calcification, comes with a lot of plaque in general, and they're in worse shape than somebody who has a calcium score of 0. So even though the calcium itself may not be the worst part of it, it's a good harbinger of who's at risk. But now that we can get into the plaque phenotypes and really look at the plaque itself, we have much better information about plaque and which plaques are more vulnerable and which plaques are going to be more dangerous for that patient.
You know, it takes me back to my medical school days when we first looked under that microscope and you first saw that plaque ruptured under the microscope. And really what we're doing, you know, with this hard work of titrating lipid-lowering therapy is actually completely changing the course of the disease. And CT has enabled us to actually look at that disease head on.
Yeah, and especially being non-invasive, it really gives us a nice insight into a very simple test. People come in, 30 minutes later, they're going home with a Band-Aid and a bottle of water, but now we have advanced plaque phenotypes to look at and can really risk stratify patients for who needs therapy and who needs more therapy.
So let me switch gears a little bit and talk about other types of medications that we use in preventive cardiology. So I want to spend a minute talking about icosapentaethyl or IPE. Now we know in the REDUCE-IT trial that patients who are being treated with statins and then got IPE, these are high-risk primary prevention patients or secondary prevention patients, had a 25% major adverse cardiovascular event reduction. Talk to me a little bit about what you found in the EVAPORATE trial and what happened to their plaque with this non-LDL-C lowering mechanism, but a different mechanism of action.
Yeah, so EVAPORATE was a trial looking at the exact same randomization as the REDUCE-IT trial using 4 grams of icosapentaethyl on top of statin background therapy or placebo, and then following them for 18 months. And we did serial CT angiography to look at plaque changes. And by 9 months, we started seeing stabilization, less vulnerable plaque, less total plaque volume, and less non-calcified plaque volume. And by 18 months, we saw even more dramatic changes where less necrotic core and more stabilization of the artery. So we saw plaque reduction in the icosapentaethyl plus statin arm as compared to the statin arm monotherapy or statin plus placebo. And we saw stabilization even at the plaque level. When we looked at those thin fibrous caps, they were getting thicker and they were getting more stable with icosapentaethyl. So really stabilization and plaque reduction both with icosapentaethyl.
I mean, that's incredible. We're really talking about a parallel risk reduction pathway here to LDL lowering. And I know one of the most common questions patients have for me is, can I get rid of my plaque? And as with statins, now we're seeing with icosapentaethyl, you can have some degree of regression. So that's really, really incredible.
Yeah, no, very, very favorable and very correlated very well with the REDUCE-IT trial. Deepak Bhatt always points out that they started seeing significantly less revascularization, stents and bypass surgeries in REDUCE-IT by month 11. And we were showing by month 9 in the EVAPORATE trial, the plaque morphology was improved, and that might explain the early benefits of icosapentaethyl.
Wow, in just a few months. And what's interesting is in the REDUCE-IT trial, it didn't matter where your triglycerides got to, you had the same risk reduction. Unlike in our LDL-C lowering trials where you get to with the LDL predicts risk reduction. So I do think this is an important mechanism that might explain that missing link.
Absolutely. Yeah, I think being on therapy is the answer. And that's what I tell my patients is that you're going to be on a statin. Now we're going to add icosapentaethyl. You're going to get 2 different mechanisms that both stabilize plaque and reduce plaque.
All right, so before I let you go, I got to ask you about the drug that every single one of my patients seems to ask me about, and these are the GLP-1 receptor agonists. We know in the SUSTAIN trial in diabetics, they showed a MACE reduction. We know in the SELECT trial in non-diabetics who were obese with cardiovascular disease, they also showed a MACE reduction. So tell me, what do these drugs do to plaque morphology?
Yeah, so we've shown 3 benefits. We did a similar trial to EVAPORATE. We called it STOP, and that was with semaglutide. And we saw 3 benefits. So benefit number 1 is stabilization of plaque. The plaque volume didn't go down as much as what we see with statins or with icosapentaethyl, but we did see that conversion of soft plaque to more calcified and stable plaque. So it's definitely stabilizing the plaque. We also saw a reduction in fat around the heart, or what we call visceral fat or epicardial fat. And I think we understand that, that you lose weight. But now we're seeing the fat that matters, not the subcutaneous fat that we pinch on our fingers when we're feeling how big our abdomen is getting. But this is the fat that's inside the body, around the organs, that's causing the inflammation and causing some of the instability. And that went down significantly That paper is going to be coming out any time now. We presented that data and the paper's accepted in JACC, so it should be out any week now. And then we're also seeing reduction in liver fat, which is, again, a very positive metabolic change, where we're seeing less metabolic syndrome and less metabolic changes that might also portend better outcomes. So fat reduction around the arteries, plaque stabilization, and fatty liver reduction with semaglutide.
Well, how fascinating. I mean, I can't wait to read that paper. And, in the SELECT trial, we saw that the curve started diverging before they had even lost a lot of weight. So again, your important work, I think, is really highlighting some of those mechanisms by which we could be changing some of those outcomes. I want to comment on a quick editorial that somebody wrote about the EVAPORATE trial. It's called, "Can EPA Evaporate Plaque?" And I think that your work has really highlighted on so many different levels all the risk-reducing pathways that we have in preventive cardiology, LDL. We talked about IPE, and now we're talking about GLP-1 receptor agonists. So I want to thank you so much for your insights today, Matt. I know I've learned a tremendous amount about plaque, and thinking about the actual plaque itself and how it modulates outcomes can really help us to figure out how to place these medications within the correct context for our patients.
Well, it's been great talking with you. Thank you very much for having me, and hopefully we'll continue to lend some insights into these fascinating meds and all the new medications that we're going to be availing ourselves of, Lp(a) and more aggressive weight reduction therapies, with dual agonists and even triple agonists. So it's really an exciting time in cardiovascular medicine.
Well, I can't wait to see more data from your group. And when I'm 60 years old, you have to promise to look at my coronary CT angiogram as well.
Done.
Thanks, Matt. And thank you all for joining us today, and tune in for the next episode of Conversations with Dr. Kohli.